As a core facet in strengthening health information systems in the OECS region, the HIV-TB Elimination Project rolled out the HIV-TB STI Clinical Management Software for case-based surveillance. A fundamental step in the process is to relaunch case-based surveillance, which is being piloted in St. Vincent and the Grenadines. Consequently, St. Vincent and the Grenadines is the first country in the OECS to officially launch the momentous occasion, which took place on Monday, January 29th at the Beachcombers Hotel. The initiative aims to standardize case-based surveillance reporting in the region. A workshop with representatives from the OECS sensitized stakeholders on the theory and practice of the newly developed HIV Clinical Management Module, HIV-MS V2, which has the capacity for integrating HIV STI-TB surveillance in the region. The main goals of the HIV clinical management systems are to improve the HIV/AIDS patient monitoring within treatment sites, to help fulfill national, regional, and donor funding reporting obligations, to enforce adherence to standards and correct standardized practices. This will facilitate quality assurance in the HIV health information system. The workshop also sought to introduce and build upon the progress of case-based surveillance in the region and chart the way forward for the case-based surveillance and identify a mechanism of sustainability for individual countries and the OECS. The objectives of the workshop introduced the HIV Clinical Management Module. It also provided an understanding of the progress and challenges of case-based surveillance in the region. It highlighted the regional plans for case-based surveillance implementation, an understanding of the key surveillance and ME indicators for regional case-based surveillance. Participants were able to view a live demonstration of the capabilities of the HIV Clinical Management Module. There was the launch of the HIV Clinical Management Information Module, the development of country plans for the implementation of case-based surveillance systems, and to ensure the sustainability of case-based surveillance under the continuation grant. The Ministry of Health, Wellness and the Environment, in collaboration with the OECS HIV-TB Elimination Project, is proud of this accomplishment and looks forward to sharing the benefits of a regional and standardized case-based surveillance system. So we're here at the regional workshop for the relaunch of the case-based surveillance, and we're talking right now with Mildred Pacaya, and she's going to tell us a little bit about her role here today and what can we expect following this workshop.
Okay, my name is Mildred Pacaya, and I'm the consultant for the case-based information system. I'm the developer of the software. So moving forward, we plan to roll out throughout the entire country. For now, we just have 5 pilot sites for the test. It has been successful, and so we plan to roll out, and then we have other countries present who also wish to roll out to their countries when St. Vincent is fully successful. So the OECS is trying to use the same software for the entire region.
5 sites were selected. St. Vincent is the first place that this is being done?
Yes.
Okay. The work that you did, how will it benefit Vincentians? How will it benefit HIV? What does that mean?
It means that they are beginning to lose funding because they have no records to back up their claims. And actually, they have claims. But most of these donors want to see records. They want to see evidence that you need these things when you ask for. And so the case-based surveillance system tracks everything and gives the appropriate reports that these funders want to see. So what it helps to do is to see to seal the gaps that have always existed with the records. To also track the patients, monitor them, look at the lapses in the health system, because actually the system can show you when the failure is majorly health care related or when it is patient related, and then when it's health care related, the people in charge can do something about it, and when it's patient related, and then they'll strategize on how to get these patients adherence, and all of this will help in the elimination process.
Okay, so in setting up this program, what were some of the things that you had to do to ensure that it's at this stage that it is now?
Well, I first of all had to develop in my house, test it in my house, show it to people who are involved in HIV to give their validation before coming out to actually want to train and pilot. First of all, the program had been going on in Dominica for 1 year, and so we had the program manager always reviewing the system to see if it's something that would work. Unfortunately, she resigned. Dominica had the hurricane, and then we moved to St. Vincent to pilot. So by the time I was coming to St. Vincent, all I needed to do was to change every information Dominica to St. Vincent, because St. Vincent is the first pilot site.
Okay, and what was the reception like in the 5 areas that you went to do the pilot?
The reception in St. Vincent generally, I must say St. Vincentians are very receptive. The majority of Vincentians are very good compared to what I've seen in other countries. The majority of Vincentians are very good.
Okay, and getting the healthcare workers on board in this process, what was that like?
It was as easy as ABC.
It was as easy?
As ABC. As soon as they were called, they all showed up before time. Hardly was anybody late, or hardly did anybody not attend. They made their input, we changed things to fit them as they want it, and the use amongst these people have been excellent. So they didn't need to call them or follow up on their use. They work with it, and when they have problems, they call.
Okay, so essentially this system is up and it would be running, or it's pretty much running because of the test that it's doing. Yeah. What is a major benefit that St. Vincent and the Grenadines would get from such a system like this?
St. Vincent and the Grenadines will have reduced population of HIV and syphilis, because so far the system has tracked positive people that have not been reported to IDC, which means that they will be outside infecting people. And
so how are you able to track those persons?
Because the system, the lab results from the lab entered into the system shows these people are positive. And so because...
So every person that does a test at the lab, it automatically goes into the system?
Yep, it goes not automatically. The lab enters the result in the system. Now what is of most interest is that the system picks out the positive results. Now remember that everything is coded. The system is not interested in the names of anybody. So they see the code that was used to start the test, trace who requested the test, and try to get the person to contact the person. Also begin to trace how the person came in for test. So somebody must have sent the person in for testing. Now, they contact the doctor, send the person in. Can you get this person? So that there's still confidentiality, and not even the lab or the system or anybody involved knows exactly who that person is or who anybody is. Unique IDs are what it is. So it eliminates that paper system where everybody begins to know everybody's secrets. No, with the system now, we can't.
Okay, but when you contact the person based on what the code reveals, what happens at that stage?
Now, the doctor who requested the test will have a level. The person would have had a level of confidence with that doctor in the first place to go there for HIV test. That doctor will have all the jobs to do to bring the person into care. At the time the person comes into care, the person does not need to report their name, just tell you your code. All of IDC works with code. So IDC doesn't need to know your name when they are treating you. Okay. They just know your code, unique ID.
So this test, does it only pick out persons who test specifically for HIV, or any blood test that is done, the system would just pick it up once it is present?
This is particularly for HIV, TB, and syphilis.
So we're here with Sister Ferosa Roach, and she is our HIV and EPI Manager, and we're pretty much at the launch of the case-based surveillance. This is a momentous time for the HIV in St. Vincent and the Grenadines. Has this launch of the case-based surveillance system enhanced your capacity, or how will it help you to do your job much better?
Okay, Nika, we are really indeed grateful to the OECS TB HIV Elimination Project and to Global Fund. This HIV case-based, electronic case-based surveillance would be a very useful tool as we move towards elimination of mother-to-child transmission of HIV and syphilis, and also as we seek to end HIV and TB by 2020 and 2030. The tool will help us in monitoring the epidemic and to track our process as we make our way to achieve these goals, as we also look at achieving the UN global target of the 90-90-90. Also, when we use the tool, analysis of the data will help us in with strategic planning, and it will also help us to where we can assign limited resources, and it will also help us to really tailor our HIV program. So the tool is very useful, and we welcome it here in St. Vincent, the Grenadines, and we are indeed honored and proud to be the OECS country piloting the system.
Very nice. What is the aim of the workshop today? After this workshop, what would have happened?
Okay, this today is basically the launching and giving a technical overview of what the system is. Tomorrow is going to be like a roadmap for the other OECS countries where we're going to sit down and decide the way forward, how we're going to move the HIV case-based surveillance. After successful piloting in St. Vincent, we're going to plan to move it to the other OECS countries. So the other technical heads, permanent secretaries, and IT technicians and other important stakeholders are here from the other OECS countries to plan the way forward for something like this in their country.
Speaking to Mildred, she said the persons here were very supportive. Vincentians came along and they gave the information that was necessary for the pilot to be successful here. As the EPI and the HIV manager and the person responsible for TB, how do you feel about that?
Well, I am elated, I'm happy, and I'm proud.
Okay.
Well, you know that Vincentians are always like to lead the way.
Okay.
When we in good things.
Good things. And the final thing I want to ask you is, this is an important fight that we have in terms of helping persons to understand, stigma and discrimination, the importance of prevention and stuff. What encouragement, it's a new year, 2018, what encouragement you give to Vincentian as it relates to their health, their sexual health, and all that they do in the preventative measures to protect themselves and their health?
Okay, I just want to say that HIV is still a very important public health issue, and HIV is all of us business. HIV can affect, and anybody can be infected by the HIV virus. So we have to join together and come on board and support each other in the fight against HIV and AIDS.
So we're here with Tomas Stevenson, and he was one of the presenters today, and he is also the recipient of an award issued here to him. Tell me about your role today at this workshop and about the award that you received.
My role today was to represent my lab. I partake inside of the training program that they have for this HIV system.
What is the name of the lab?
The name of my lab is Caribbean Reference Lab. It's located in Paul's Avenue, opposite Bishop College, right? And we do testing there for various samples, to blood, urine, and everything, right? So the HIV unit, the secretariat, they contacted us and they wanted us to partake in the exercise. And when I went to the training, I missed the first day actually, right? But on the second day when I went, they said that I did very well in, the training process and everything when they showed us the program and everything like that. Well, besides that, I do have a bachelor's in IT, so I understood what was going on and everything. It wasn't hard to pick up. This system is very simple in a sense. It's just that it's a bit tedious to put in the information. So I alerted them to that my private lab, the people won't have time to sit down and collect all these informations and stuff. So the lady, the programmer, which is Mrs. Pacaya, I hope I pronounced the name right, she said, okay, well, she would walk along with me and see what we would need to be able to, create a path for the labs themselves. And then a few days later, they were going to have this ceremony, and I saw, my secretary told us about the email and stuff like that and said that we would have to be represented and they would send me, and here I am today. Basically.
Okay. And how beneficial do you think this experience has been to you and the work that you do?
Yeah, it's very beneficial. It's good to see that information could be collected in such a way that it could form statistics about our island or region, which could be used to help further stem the spread of some of these diseases. And I'm praying that they further expand it to other diseases like probably like HTLV and stuff like that, and herpes and things like that. So they could see correlations to how these diseases, probably match up with each other, and how people and age groups and everything, which I have seen on the system display already, right? So it's just to get all the information in one database and it would be nice to see all this done, especially how I did build some of these programs in my bachelor's, especially doing our little projects and stuff.
And none of the things that you've learned would compromise patient confidentiality or anything like that?
You see, if she creates a special sector for the private labs, because I know patients come into a private lab to avoid, having some information put out there about them, because they might use a code and stuff like that. Won't necessarily give us their full name, where they live, and all these things, right? Those are patients like probably more coming off the street. I understand this. So, therefore, if she creates a special sector on the program itself that could give us, that we collect certain information. Yes, I understand that you need to have information because it's a case-based system, and it was indicated today that yes, you need to collect some information and stuff. So Mrs. Pacaya said that she would create a special part of it to enable us to collect certain information without jeopardizing totally this patient confidentiality that's supposed to be there for these patients who don't want to give out anything. Also, and don't affect the lab in any way of like losing funds because of this. Because if the patient's saying, oh well, your lab never used to do this before, and why are you asking us all these questions? Because everyone would not want to partake inside of this. So if we could probably also educate the public, and they probably have like programs with radio, TV, via the internet or whatever, right? Facebook, all these social media sites. If they could probably have programs to educate the public a little and tell them, well, it's beneficial to the country, to the region, as a whole, it probably might, ease the mind of some patients to partake inside of the exercise to get information from them.
So we're with Dr. Cleophas DeVay, and he is the coordinator for the case-based surveillance system. And you're going to tell us a little bit more about your role and how would the system benefit not only St. Vincent and the region, but the region.
Yeah, well, my role is the project coordinator of the OECS HIV TB Elimination Grant, as QRBC 1037. The goal of the grant is more or less to reduce the incidence of HIV in line with the 1990 targets, and part of that strategic objective, is to strengthen the surveillance systems for HIV, STIs, and TB. So strengthening HIV case-based surveillance is part of that particular strategy. It's an essential component of the grant, and at this particular phase, we are looking at strengthening HIV surveillance throughout the entire OECS, and using the HIV Clinical Management module that we just developed and having it rolled out in each member state.
Okay. St. Vincent is the first place where it has been done so far?
Well, the system actually started in Dominica, and they were about to go live, but unfortunately Hurricane Maria came and sort of, set us back a bit. But fortunately, the consultant was able to emigrate to St. Vincent and the Grenadines, and she more or less transferred the technology from Dominica to St. Vincent and the Grenadines with the requisite training, manual development, work that's needed to duplicate the process, in St. Vincent and the Grenadines, and now to be in the position to go live, in St. Vincent and the Grenadines at different sites around the country. Those sites are both public and private sector and civil society. So we want widespread implementation, and we've been able to achieve that thus far.
Okay. For the layman who may be listening to this interview and not understanding, what does this mean for St. Vincent? What does this mean for the OECS? What does this mean for the region? Can you just break it down a little bit for us?
Well, putting it as simply as possible, we will be able now to collect data and use that data to see where all of the HIV cases are, to know the risk factors of people with HIV, apply that to specific populations, men who have sex with men, sex workers, transgender, and use that information for effective planning, for the future public health interventions, and also for resource allocation. You see one particular area in the country has a high rate of HIV, then we'll have to focus more of our education and testing in that particular region. So that's one. The second is that with the data now, we can actually have the evidence to support our grant proposals for more money as well, because there's no more estimation. It's the real data, that you actually have. And that's very important. The other thing is that with this particular system, we'll be able to have the data, fit the data requirements for the validation or elimination of mother-to-child transmission of HIV and syphilis, because we have actual data that can be verified for HIV and syphilis in pregnant mothers that can be used and say, well, this is it. We have the real live information, so you can certify us as having eliminated mother-to-child transmission of HIV and syphilis. And we want to move on as well to TB elimination. So having that data is very, very important. The third thing is that with that data, we have to ensure that it's valid and it's accurate, and having a system where you have the automatic inputs of standards. You don't really have to, it'll give you more like a check on the system to see people are doing things properly.
Right.
So you have better quality assurance. You know that the data is valid. And with quality assurance, you are more or less complying with international standards, for health information. So issues like confidentiality, all those things, are properly aligned. And as well, that will reduce the risk of human error, and also litigation if something goes wrong. So just having that system really, really strengthens our capacity to provide quality information, quality data.
This work that you're doing is very extensive and it's critical. We are having this issue in the region still in 2018, where we're trying to cut back or try to eliminate as best as possible stigma, discrimination and stuff. As your role as coordinator, what message do you want to give to persons for 2018 in relation to that and their approach to their whole sexual and reproductive health?
Well, I think that stigma and discrimination is a serious issue because, there's both self-stigma and external stigma. For patients who have HIV, it's important that they become empowered and know that they just need to take care of themselves, take their medication, and they live a long, healthy, and productive life like everybody else. And HIV is no more deadly a disease than anything else. And actually, it's actually safer than before. You don't die right away. Once you take your medication, you can live a long life, and it's not like you have diabetes where you have to take injections, and monitor your blood sugar up and down. If HIV, just take your meds and you're okay. So that's important. They continue to know that things are much better than they were before, and that their outlook on life is just as good as anybody else. With regards to the stigma and discrimination, things are improving in the society. Everybody's more aware of HIV now, and there's no need for stigma and discrimination. And that we as a society need to take measures to reduce that, putting ourselves in the person who's HIV in their position, to know what would you do, how would you feel, if you were being treated like that, and actually check yourself, to say, well, I shouldn't be doing this because it was my mother, my sister, my father, I wouldn't want that for them, We've also tried to have a psychosocial support plan, national plan, which we hope to implement perhaps sometime in the near future, perhaps in the next grant, in terms of measures that can be taken to reduce stigma and discrimination in each of the OECS countries, and these can pertain to patients' Bill of Rights, patients knowing what their rights are, and also code of conduct for healthcare practitioners, knowing how you're supposed to behave in certain situations and what's right and what's not right, and protecting patient confidentiality. So all those issues we want to pursue further in the next grant, and we collectively moving as a society to reduce stigma and discrimination, because of it can have some harmful impact, people's confidence, their will to live, and that sort of things. But we're moving in the right direction with the support, not just of healthcare practitioners in the public service, but also civil society, all the partners, Planned Parenthood, LGBT associations, everybody moving together and reducing stigma and discrimination